morning, everyone. Myself, Dr. Harshil. I'll be presenting on obstructive jaundice. So she's a 78-year-old female. She presented with chief complaint of upper abdominal pain and yellowish discoloration of sclera and urine. On history of presenting illness, she was apparently all right 1 year back when she started developing complaint of upper abdominal pain, which was insidious in onset, mild to moderate in intensity. It was dull aching type and non-radiating. It was not associated with any food intake or no aggravating factor, and got relieved on oral analgesics. She also had the yellowish discoloration of sclera and urine, which were insidious and progressive in nature, associated with pale colored stool, however, no pruritus. Patient took conservative management for the same from nearby hospital. However, over a course of 1 week, she also developed fever, which was high grade as per description. However, no documentation associated with chills and rigors, requiring IV medication and admission. Following admission in October 2023, patient was evaluated with blood reports, CT scan abdomen, and she underwent an endoscopy with a stent placement. Her symptoms was resolved. After the stenting, subsided, pain was jaundice relieved. Patient was advised for surgery, but as he was asymptomatic, they were lost to follow-up and did not come up further evaluation. Patient was asymptomatic over period. There was no history of any intermittent abdominal pain or fever during this time. But patient started developing similar complaints of upper abdominal pain, fever, and discoloration since last 1 week. She was admitted in hospital, underwent endoscopy and stenting again, and then she was referred to the surgical department for further evaluation. There is no history of any prodromal symptoms, loss of appetite or loss of weight. There is no history of nausea or vomiting, and no history of abdominal distension. In past history, there is no medical or surgical past history. Vegetarian diet without any addiction, having the pale color, regular bowel habit, no significant family, and gynecology. She is a postmenopausal female, achieved menopause 25 years ago and having 2 full-term normal delivery. So, in summary, she is a 78-year-old female with history of upper abdominal pain, jaundice, and fever 1 year ago. Got admitted, evaluated, and symptoms relieved after stenting. And currently, she also developed similar complaints since 1 week.
Back to your presenting earlier before this. So if you say upper abdominal pain, it is always better to say whether it is right upper abdominal, mid upper abdominal, left upper abdominal. Most likely, if it is with jaundice, it would be right upper abdominal pain. It is always better to say that, because then your thought process gets limited to that area of the abdomen.
Yes.
And go to the negative history. Yes, this one. So why did you ask for prodromal symptoms?
Sir, 1 year back when it was associated with jaundice and fever, to rule out hepatitis and associated prodrome to that hepatitis. Viral hepatitis.
Why would a patient with hepatitis need stenting?
That is true, sir. This is just for the first.
At this level, the history and examination and discussion has to be a targeted one. And for an MBBS student, it is all right that he has to ask everything. For you, even if you were to mention, more important is loss of appetite, loss of weight, nausea, vomiting, and abdominal distension rather than prodrome. Even if you want to mention it, it should come in the end. Although I don't think that you should at all mention it, because at no point you are considering hepatitis. Hepatitis you would consider only if the jaundice is of a short duration, 4 weeks, 6 weeks, maximum 8 weeks or 12 weeks, not beyond that. And here, of
Stent.
course, there is a history of endoscopic stenting. So this question becomes superfluous.
Yes, sir.
What do you
Should
think
we
will happen to this?
mention this, sir, in the presenting illness when I have mentioned it for the first time that she had developed fever and jaundice?
Yeah, at that time, maybe you can mention it because
Okay.
at that time you are not clear that 1 year ago. But once you know the entire history, you are presenting the case in the exam. In the
Yes.
exam, presentation is after a thought process. Sometimes you have to delete something, sometimes you have to go back to the patient and ask some more history.
Yes.
So I personally would not accept mentioning history of prodromal symptoms in a case like this.
Yes.
It would be superfluous.
Yes.
So what do you think has been happening?
Sir, considering the symptoms, my first differentiate will be choledocholithiasis with retained stones.
Why do you
And
say retained stones?
uh, sir, with it, she again developed features of cholangitis and obstructive jaundice within 2 years of ERC clearance.
Go back to the first endoscopic intervention. After this, the next intervention.
After 9 months.
My question is, was the stent removed?
Sir, by history, there is no mention of whether stent was removed. But she didn't intervene stent removal after first stenting. For 9 months, she was lost to follow.
So a patient who has undergone stenting, and that stenting obviously relieved all her symptoms.
Yes.
So if you are thinking of
Complete
CBD,
clearance.
most probably CBD was cleared. Now
Yes.
she presents again with cholangitis. So that is why you are saying retained CBD stone. Is
Yes.
that the only possible cause?
So stent block with sludge
The
can also
stent
be.
block, stent which has been there for 9 months is very likely to get encrusted with the bile salts and bile pigments. And itself, as a foreign body, it can cause cholangitis.
Yes.
So both the
So
possibilities are there. Any other
yes.
possibility?
Sir, another differentiate would be Mills syndrome with progressive obstruction of the mid CBD leading to the similar symptoms. And in the last lower I would like to put any malignant cause also, considering her age, any lower CBD pathology, distal CBD or perium.
Good. So you should not rule out malignancy. 9 months or 1 year is not unknown for an untreated malignancy. Which malignancy?
Sir, any slow growing periampullary can be there. Even CA head of pancreas can also present late with pain abdomen.
What are the malignancies which can cause obstructive jaundice? What are the common malignancies which can cause obstructive jaundice?
Uh, Sir, periampullary malignancies, including distal cholangiocarcinomas, ampullary malignancies, CA head of pancreas. For mid CBD, CA gallbladder, and any other malignancy with portal lymphadenopathy causing obstruction. Uh, any advanced pyloric malignancy obstructing distal CBD or mid CBD can also present with obstructive jaundice. And in hilar cholangiocarcinoma.
So out of all these, in increasing order of biological aggressiveness, how do you place them? Which is the least
The
aggressive?
distal cholangiocarcinomas I'll put first as a very slow growing and persistent for years, followed by perium, followed by CA head of pancreas and CAGB being most aggressive.
Yeah. So in general, the periampullary malignancies and cholangiocarcinomas, they are less aggressive as compared to gallbladder and pancreas.
Yeah.
Untreated gallbladder or head of pancreas for 1 year is less likely. But untreated periampullary, I think I'm sure all of us have seen patients with periampullary carcinoma who got stented as a preoperative procedure and then they were lost to follow up and then they come back after 1 year. I have seen even 1.5 years. So untreated periampullary or a cholangiocarcinoma going on for an year or so is not unusual, but gallbladder and pancreas is less likely. Okay, let's proceed.
With this history on general examination, patient was conscious oriented,
Any,
moderately built.
sorry,
Her BMI,
any other benign possibility?
uh,
Cholangitis responding to stenting and then coming back with cholangitis. You said CBD stone. Any other?
so any parasitic infiltration, ascariasis,
Also, she is elderly. That possibility will be more likely if the patient was relatively young.
yeah,
Choledochal cyst. The next common cause of benign obstructive jaundice after CBD stone is choledochal cyst.
choledochal
So
cyst.
you can't rule it out, although you can say that 78 is not the usual age when a choledochal cyst would present for the first time. Most patients would present in childhood, adolescent, or young adult, but it is a possibility.
Possibilities. Uh, she is conscious oriented, moderately built and nourished. Her ECOG performance status is 1. Her BMI is 19.6. She is vitally stable. Clinically, icterus is present. No pedal edema, clubbing, or cyanosis. There is no scratch marks, no supraclavicular lymphadenopathy, and her back and spine is normal. On abdominal examination, her inspection, abdomen is flat, umbilicus centrally placed and inverted. All quadrants move equally. There is no visible mass sinuses. There is no peristalsis or pulsation seen, and hernial orifices are normal. On palpation, abdomen is soft. There is no local rise of temperature. It is non-tender. No palpable lump or no hepatosplenomegaly. On percussion, liver span is 14 centimeter and no shifting dullness is there, and auscultation is wow.
What palpable lump you were looking for?
Yes, sir.
What palpable lump you were looking for?
Sir, gallbladder
You
in
say
case of
that you should, in a patient with obstructive jaundice, you must say whether gallbladder is palpable or not. And you should say gallbladder. You shouldn't say palpable lump. Lump could be
okay.
anything. It could be an epigastric mass of CA head pancreas. Rarely, it could be very much enlarged lymph node. She's a thin-built patient. It could be a large omental or peritoneal deposit. So, in all patients with obstructive jaundice, you should say gallbladder is palpable, not palpable. If it is palpable, is it a distended, smooth, oval, pyriform, regular
Moving with
gallbladder which has movement with respiration and side to side mobility, or whether it is any shape, firm to hard, irregular surface, nodular surface with no side to side mobility, GB lump. That is
yes.
one of the most important clinical findings in a patient with obstructive jaundice. Don't generalize it by saying no palpable lump.
Okay, sir.
Yes.
On digital rectal examination, finger was stained with pale colored stool and no other abnormalities, and other systemic examination was essentially
In
normal.
the stool, in the stool, you should specifically say no melena. Although you are
No.
saying pale colored stool, but say no melena. So
Oh,
that tells me that you have looked for melena. In which
oh.
cases you will find melena on digital examination.
Sir, periamp with sloughing of the ampulla and bleeding.
All periampullary carcinomas will have
No,
melena.
no, no, sir. If there
Which
is
ones?
ampullary one with sloughing of ampulla,
What is ampulla?
ampulla of Vater, uh,
What is ampulla?
sir, it is the outpout.
No. Ampulla is the common channel formed by the union of the lower common bile duct and the terminal pancreatic duct. Papilla is the nipple-like projection on the medial wall of the second part of duodenum where the common channel opens. When you do a side viewing endoscopy, what you see is papilla. You can't see the ampulla. Many endoscopists also do not kind of pay attention to this and they write ampullary growth. That is not correct. It is a papillary growth. Ampullary growth cannot be seen on side viewing endoscopy. So it is the papillary type of periampullary carcinoma or a peripapillary duodenal carcinoma, which is within 1 or 2 centimeter of the ampulla, which will cause melena. An ampullary carcinoma, lower end cholangiocarcinoma will not give rise to melena. CA head pancreas may give rise to melena if it has infiltrated the duodenal wall
Duodenum.
and the mucosa. If there is duodenal mucosal involvement, it can give rise to melena. Okay.
Yes. So on summarizing, sir, she's a 78-year-old female with history of pain, abdomen, jaundice, and fever 1 year back, which got relieved, diagnosed and got relieved on ERC stenting. And following which, she, after 9 months of asymptomatic period, she developed recurrent episode of similar right upper quadrant pain, jaundice, and fever. And on clinical examination, she is icteric and no other positive findings.
So how has the examination helped you in changing or modifying your differential diagnosis? Does it help?
Uh, so there is no palpable gallbladder. However, post ERC stenting, we cannot comment on the status of gallbladder in relation with the distal CBD block. So in this case, sir, after an intervention,
Better way to say that will be that in a patient with surgical obstructive jaundice, a palpable gallbladder decides whether the block is at the lower end, mid CBD, or upper end. But since the patient has a stent in situ, that finding becomes irrelevant. Do you know of a situation where even after stenting, the gallbladder will remain palpable?
yeah, sir, if CA gallbladder NAC of CA NAC GB is there, then even after stenting, it won't get relieved.
So gallbladder cancer, which is involving the neck, causing cystic duct block, mid CBD cholangiocarcinoma, which is blocking the cystic duct, and
Yes.
a stone impacted in the cystic duct.
Yes.
Suppose you have cleared the CBD stones, but there was a stone impacted in the cystic duct also, which is causing a mucocele. Then also the gallbladder will remain distended. So it is not that in every case after stenting the gallbladder will decompress. It depends on whether the cystic duct is patent or it is blocked. The block could be because of gallbladder cancer, because of a mid CVD cholangiocarcinoma, and because of a stone. In Mirizzi, usually gallbladder is not distended because Mirizzi is a manifestation of long-standing chronic cholecystitis. In most patients with Mirizzi, the gallbladder is small, contracted, shrunken. Very unlikely that gallbladder will be distended in Mirizzi. In fact, some texts say that if the gallbladder is distended, it rules out a diagnosis of Mirizzi.
Yes.
Okay, so she comes to you now with a stent in situ, isn't it?
Yes.
So you have said endoscopy was repeated and stenting done. From this, I don't know whether you mentioned or not. When was this done?
So 9 months after the in October, the last was one done, and this was done in July 24.
So when the question is asked, when it is done, don't relate it to a previous event. Relate it to the
July.
current. Just give me a minute. I have an important call.
Yes.
Sorry.
Sir. So second stenting was done in July 25th.
So now we are in September. You have to tell the current status. What was the outcome of the current this stenting? She presented with a repeat episode of cholangitis. So you have to say endoscopy and stenting was done on this date in July, and currently she is what?
Actually, sir, she is our follow-up patient. She got operated last month. So
Okay. So then you say that currently means whenever this history was taken. So you say currently she is asymptomatic.
So following stenting, patient symptoms again got relieved and she was asymptomatic.
Yes. Okay. So she comes to you at that stage. What will you do?
So first of all, I would like to review all her previous documents, including the CT scan and endoscopy done at the first time in October 23, and her blood reports.
Yeah, let's see. We have them.
Sir, CT scan we have, endoscopy was done outside, so we don't have. This was blood investigation. Shall I go through it?
Yes.
Okay, so in October 23, when she was presented first time, sir, she was having she was having direct hyperbilirubinemia with raised OTPT and total count suggestive of cholangitis with obstructive jaundice.
So she has
Uh,
all the features. You should say she has leukocytosis. She has polymorphonuclear leukocytosis. The
yes,
differential count neutrophils are 89%. She has hyperbilirubinemia with raised alk-phos and raised enzymes, all features suggestive of cholangitis.
cholangitis.
Then,
Yes, sir. Following which she was stented, and during follow-up, she underwent only blood reports, which showed complete resolution of cholangitis with normal bilirubin OTPT and total count also normalized. Following which, there was asymptomatic period of 9 months, and she did not get done anything, and presented
say
in
that
July 20.
you should say that the alkaline phosphatase elevation stays.
Yes,
Alkaline phosphatase hasn't settled. It remains almost the
yes,
same,
same.
slightly increased. Yes. Then
Yes. And then again, she presented in July 24 with features suggestive of obstructive jaundice and cholangitis with increased OTPT and raised alkaline phosphatase. However, at that time, total count was normal, so no leukocytosis. And during this period, she seems to have nutritionally deprived because her hemoglobin also serially dropped, and there is one single value of albumin which is lower than the normal. And however, CA 99 done during this admission time was done in with bilirubin more than 4, but it is significantly elevated more than 1000.
so what is the importance of this?
Sir, this CA 99, sir, ideally should have been done with normal bilirubin after cholangitis was resumed after again stent exchange, but that value is not available. However, such high, we can think of a malignant cause if this high
So the
CA 99.
answer should be that ideally the tumor marker should be estimated when the patient is anicteric, but a very high level, more than 1000, strongly suggests that there is a possibility of malignancy. It can be
Yes.
seen in benign also, but it strongly suggests that there is malignancy. Next.
So CT scan, which was done in October, we don't have any videos and films are also limited. But as we can see in this contrast and on CT scan, there is peripheral as well as central IHBR seen. IHBR dilatation is seen in the CT scan, and on sequential, we can see this right and left confluence followed by common hepatic duct. On tracing the common hepatic duct down, here, sir, in the last two, we can see there is abrupt cutoff. This is the common hepatic duct dilated, and
Is
this
this
is the
common hepatic
divided.
duct?
Sorry,
This is
CBD,
common
CBD.
intrapancreatic. You should say
Yes, sir.
the
Intrapancreatic.
radiologists describe everything as CBD. We should
Yes,
be able to say common hepatic duct, which is above the junction of cystic duct, the common bile duct in the hepatoduodenal ligament, and then the intrapancreatic part.
yes, sir. So this is the intrapancreatic part of CBD, and there is abrupt cutoff. However, I could not appreciate any intra CBD mass lesion or peripancreatic lesion. In this, gallbladder is also over distended. So, if clinically examined during this time, I think GB must be palpable uh, in October.
What do you see in the fourth column in the first row?
Fourth
Fourth.
column first. This one, sir. This is the gallbladder. This must be cystic duct with the walls spiral.
Yeah, you see, all students, please see how beautifully you can see the valves of Heaster. And at that time, the GB was distended. And because the cystic duct is patent, once the stent was placed, GB has got decompressed. ये वाला picture मुझे भेज देना. I'll
Yes,
include it in my book. It shows these
yes.
valves very beautifully. Yes. So
So
again,
on
sorry, go back, please. So second last cut of the CT, you see a well distended, dilated common bile duct with nothing inside the lumen. The second last.
Yes.
muscle. Yes. And then the very next one, as Harshil pointed out, you don't see any CBD, but there is no mass either inside or outside. So this strongly suggests a periampullary carcinoma, not a head pancreas, not an intraluminal ampullary carcinoma. What else would you like to show us?
Uh, Sir, arterial and venous anatomy.
Before going to arterial, anything else? In a lower end block, what else you should show us? This is obviously a lower end block, just at the
Yes.
level of ampulla or papilla.
Sir,
Pancreatic duct.
yes, pancreatic duct. Yes.
Evaluation of CT is not complete without looking at the pancreatic duct. Show us the
Yes, sir.
pancreas. Where is
So pancreas is atrophic. There is no feature of any calcification or anything, but it is atrophic, and there is this dilated MPD
I won't say dilated, just prominent.
prominent.
Just seen. It's not dilated. Even in the whatever little parenchyma is seen in the head of the pancreas, you
Yes.
don't see a
Yes.
dilated. Is it?
Yes.
Yes. The next one, you see very little parenchyma to the right of the portal vein and in front of the CBD.
Yes.
Go to the first column in the last row. Again, in front of the CBD. No, last row, third row, first column. Yes.
Yes.
In front of the CBD and to the right of the SMV, you see a little bit of pancreatic parenchyma. I don't know whether there is a hypodense. Just enlarge it a little bit. Is there a hypodense mass inside? It doesn't look like.
Yes.
But you don't see a dilated pancreatic duct anywhere, just a prominent pancreatic duct. Okay?
Yes.
So,
And in
that
reports,
is
they have mentioned.
what does that suggest? If the CBD is dilated and PD is not dilated, what does that suggest?
So it is more suggestive of distal cholangiocarcinoma rather than ampullary pathology.
Because if it is an ampullary growth or a papillary growth or a peripapillary duodenal growth, then the obstruction is beyond the joining of the two ducts. So ideally,
Yes.
both ducts should be dilated, theoretically speaking. If only CBD is dilated, it is lower end cholangiocarcinoma. In a
Yes.
patient, only pancreatic duct is dilated, CBD is not dilated, then probably it's a tumor in the body or neck or the distal part of the head of the pancreas. Okay.
Yes.
So whenever you are looking at the CT of a patient with obstructive jaundice with a lower end block, you have to show us both CBD and the PD.
MPD.
And then come to the vessels. Show us the vessels.
So starting with the portal vein, tracing it from upwards. This is the right portal vein. This is the main portal vein. Tracing it downwards, sir. This is again the portal vein. Now here it looks like that splenic vein is joining the SMV, and from here this is the superior mesenteric vein. This is not triple phase. However, left to the superior mesenteric vein, we can see the SMA also in some cuts.
Vessels are important only if there is a mass in the head of the pancreas.
Yes.
In a lower end cholangio, in a periampullary, vessels are usually not important. Lower end cholangio, it could be because it may be directly infiltrating the portal vein, but otherwise, they are important only if you see a mass in the head of the pancreas. But yes, as a routine, you should say, so in a case like this, you should say that although there is no mass in the head of the pancreas, but I can see the SMA and SMV and they are normal.
Yes, sir. And there is no any space occupying lesion in the.
How do you describe the vessels on CT and what are the features which suggest that vessels may be involved?
Sir, in vessels, sir, shape of the vessel, any intraluminal thrombus present or not. In shape also, sir, there is encasement and abutment. If it is less than 180 degree or involvement, sir, it is abutment. More than 180 is encasement. And any change in the shape of the vessel, any teardrop change due to external compression, And if there is any intraluminal thrombosis, either tumor thrombosis present.
Yeah, so you look at the shape, both SMV and portal vein will be either round or oval in shape. You look at the caliber. The caliber should gradually increase as you go from SMV to the portal vein. And you look at the outline, it should be regular. Plus, in patients who are well nourished, there will be a fat plane between the pancreas or the tumor and the vessel. So the first change which occurs is loss of fat plane. But you have to be careful. In a patient like this who has a low BMI, where there is very little fat in the body, there may not be a fat plane. So you have to be careful. In CA esophagus, in CA head pancreas, if there is no fat plane, it doesn't mean that the vessel is involved. It may be because there is no fat in the body because of weight loss or low BMI. Next is the angle of contact. If the angle of contact is less than 90 degrees, then you say the vessel is not involved. If the angle of contact is 90 to 180 degree, you say it is abutment. If it is more than 180 degree, you say it is involvement. Then you could have a complete, before that you could have a thrombus, you could have a change in the shape. So from smooth, round or oval, it becomes irregular. There could be change in caliber. So you see the vessel below the tumor, it is X millimeter. You see vessel above the tumor, it is X millimeter. But at the place where the tumor is, it is smaller. So which means there is compression or there is decrease in the diameter. So change in caliber, then change in shape. And instead of smooth, round or oval, there is a what is described as a teardrop appearance.
Yes.
Then there could be thrombus in the vessel. And finally, it is complete occlusion. So these are terms which are used by the radiologist to describe, and in increasing order, they suggest involvement of the vessel. If there is a thrombus, if there is a change in shape, if there is a change in diameter, if obviously there is complete occlusion, they are definite evidence of involvement, whereas the other are suspicious evidences of involvement. Yes.
So in the report, sir, there is enhancing nodular mass lesion in the distal lower end of CBD near ampulla, size of 1 by 1.3 centimeter, causing upstream dilatation of CBD and IHBR, likely malignant pathology. There is relative atrophy of pancreas with no significant MPD dilatation, and there is small lipid attenuation lesion in the body of pancreas measuring 4 by 6 mm. And multiple lymphadenopathy in the port.
So they have reported a mass inside the CBD, at least here, I don't see, but maybe
Yes,
in the...
this cut is too big.
Yeah, between these two cuts, maybe they saw something which they have reported on the screen.
So following which, sir, we don't have the first ERCP, second which was done in our hospital. It has there is a periampullary growth with stent in situ, and that stent was blocked. Was removed, CBD was cleared, and again and was placed.
This is the second endoscopy.
Yes, this is the second endoscopy, sir, where there was tumorous papilla with blocked plastic stent. CBD stent was grasped, and there was a lot of sludge and small calculus of 3 mm coming from papilla. CBD was cannulated. Cholangiogram, there was CBD was dilated 2 centimeter and with dilated IHBRD. There is balloon sweep and CBD clearance and restenting, that is stent exchange was done, following which free flow of bile was seen.
We don't know whether the growth was there at the time of first endoscopy or not.
No, sir, that report is not available. However, patient relatives were told that you required intervention. No, sir.
Yeah.
First ERC report is not available. However, the relatives were told that she requires a definitive surgery following that ERC only. No biopsy was also taken.
Sorry?
Even
I think roads blocked, hai na?
in this also, sir, we can see a bulky papilla with irregular growth and mucosal ulceration redness. This is the sludge which they drained out with a stent exchange. However, no biopsy was taken during this time.
Yeah. So what would you do now?
Sir, once stent exchange is done and patient is cholangitis, the cholangitis is resolved. As the last scan was 9 months old, I would like to get done another triple phase CT scan to look for the current status of the tumor.
Has it been done?
Yes, sir. So this is the non-contrast cut of the CT scan, which shows a stent enhancement, as you can see from CHD up to the, and there is no significant intrahepatic biliary radical dilatation. Some dilatation of the hepatic duct. On contrast, enhanced venous phase, there is dilatation of central IHBR with common hepatic duct dilatation and a stent in C2. With gallbladder is now decompressed. There is no significant dilatation. On tracing the stent or CHD below, there is CBD, and we can see that stent is finished here, most probably in duodenum. This is the duodenal wall. However, no growth is again seen, perium growth.
Even the CBD dilatation has subsided.
Yes.
Which rules out a possibility of a choledochal cyst. In choledochal cyst, even after stenting, the CBD dilatation would persist to some extent. Here, CBD is almost got decompressed.
Yes, and here's a similar pancreatic atrophy with prominent MPD is seen. However, no significant dilatation of main pancreatic duct.
Why did you do a repeat CT scan?
Yes, sir.
Why did you want a repeat CT scan?
So now to look for the operability of the tumor, whether it can be resected.
What decides operability?
Sir, locally, first is any distant metastasis. I cannot see any liver SOI.
That was the primary purpose.
Yes.
So if you believe in the hypothesis that when you place a stent, especially if you place a stent after doing a papillotomy, there are some groups, including the SGPGI group, which believe that this increases the risk of distant metastasis. So you should have commented that there are no SOLs in the liver. You should have said that there are no distant lymph nodes.
So in visible lung field, there is no any lesion in the lung, and as far as we can see in the pelvis, there is no fluid or ascites.
Yeah, so you should mention all these, although you can say that this is understood, but nothing is understood.
Yes. In the arterial fissure also there is similar finding. Our lower cuts defining, even there is artifact after stenting, so we cannot appreciate any tumor in the lower end also, near ampulla, which was visible in the ERC images.
Do you see any nodes here?
Nodes, sir, this one.
Yeah, what is that? What is this?
Sir, inter-aortocaval lymph node.
So how would you describe it? Describe that node.
This is oval with regular shape, and sir, I don't know.
Scale is not there, but you should be able to measure the size, and then you describe the enhancement, whether it is homogeneous or heterogeneous. So what makes a lymph node suspicious on CT scan?
Sir, change in the shape. First, any size more than 1 centimeter. Then change in the shape of the lymph node, more vertical, more horizontal than vertical diameter. Any loss of
change in shape is from normal oval to a rounded. Oval is the normal shape of the lymph node. Rounded is abnormal. Okay. So size, shape change from oval to round, and heterogeneity, hypodensity or necrosis in the center. These are the features. So we don't know the size, but it looks as if it is not significant. But there is a node, the pre-caval node or aortocaval node. Okay. Yes. Go to the same scan. Show me second row, first column. There is a hypodense area in the segment 4 and 5 of the liver? What is this? Is that not a space occupying lesion?
So in single image, I would like to see the same lesion in arterial as well as. So this one you are saying?
See the next cut. So this is what is known as the partial volume effect of the gallbladder. See, any lesion which is lying close to an area of a solid organ, if you see above or below, you will see it appears, if you see in isolation, it will appear as if there is something, but when you see in continuity, you don't, you see the adjacent structure. So this is what is described by radiologists as the partial volume effect.
Partial.
That is why you should never comment on one section of the CT scan. You should always see above and below.
Yes.
Okay, what will you do?
Sir, as seen in CT scan, the disease looks resectable. So I would like to first see for her cholangitis, whether it is resolved or not. If it is cholangitis and sepsis free, and her nutritional status is up to the mark that she can be taken up for surgery after improving that, I would like to take her for a staging laparoscopy, followed by pylorus resecting pancreatic or duodenectomy.
What about tumor marker? It was high. You want to?
Sir, after cholangitis resolvement and once bilirubin is normalized, we should repeat it, sir, for prognostic purpose in the follow-up. However, it won't change current management.
Yeah, so that's right. Whatever level you get, it is not going to change your plan of management. Second, you didn't do a biopsy at the time of repeat endoscopy. Should you have done? Would you like to do it now?
No, sir. After again, repeat endo side viewing and biopsy, I don't want to do. But at that time, when cholangitis was there and we were doing stent exchange, a biopsy should have been done. It is not mandatory, but as we are.
Yeah, your answer should be yes. It should have been done at that time, but I would not do a repeat endoscopy to do a biopsy because there is a strong radiological, endoscopic, and clinical suspicion of malignancy. So even if biopsy comes negative, you are going to treat it like a periampullary carcinoma. You are going to operate upon it.
Yes.
So although it should have been done, the dictum is that in periampullary or pancreatic malignancy, you make every possible attempt to get a tissue diagnosis. But it is not mandatory to have a positive tissue diagnosis to operate upon the patient. So when we say you make every attempt, it starts with side viewing endoscopy and biopsy. If there is no growth there, then you can either do a brush cytology from inside the ampulla, inside the CBD, or you can do an EUS guided FNAC. But you would never do a percutaneous ultrasound or CT guided biopsy if there is a mass in the head of the pancreas. Then you operate on radiological and other suspicion.
Yes.
And you should always say that if you are operating upon a patient without a tissue diagnosis, then counseling and consent is very important. That a small possibility, which ranges anywhere from 5 to 10%, that the final histology may not show malignancy. That becomes important. That is of it doesn't trouble the patient if the patient becomes recovers all right. But suppose there is a mortality, then it becomes an issue. So that is why counseling and consent is very, very important from a practical point of view. And most examiners would like to that when you are operating on a patient and doing a PD without a tissue diagnosis.
Biopsy. Yes.
Why staging laparoscopy? You said staging laparoscopy. Before that, would you do a PET scan?
In peri-am, sir, and there is no any suspicion of any other lesion in the abdomen on triple phase CT scan, I would not like to go for PET CT scan. And in any straightforward peri-am, if she was being operated in October, there is also we can skip staging as it is not known for peritoneal or omental mets compared to CA head of pancreas and CA gallbladder. However, with this course, 1 year long course of the disease, I would like to do a staging laparoscopy to rule out any subcentimetric nodules in the peritoneum or liver.
In fact, PET scan also, maybe somebody may have a stand that if you do a repeat tumor marker level and it is still high, even after the jaundice has been resolved, some people may go for a PET scan. Although you are right that PET scan has a role more in see ahead pancreas rather than in periampullary carcinoma. But here, since this is a lower end cholangiocarcinoma, if the tumor marker level is still say above 1,000, one may go for PET scan. And for the same reason, long duration endoscopic stenting, high CA99 levels, staging laparoscopy. So in CA head pancreas, the value of a CA99 level is one to decide whether PET scan should be done, to decide whether staging laparoscopy should be done, to prognosticate, and for follow-up. So all these are uses or advantages of doing a CA99 level. Those advantages are much less in a periampullary as compared to CA head pancreas. What do you anticipate? This PD is going to be easy, difficult for you?
No, sir, because of recurrent cholangitis, at least twice documented, and pericholedocal inflammation is severe. So dissection in porta will be difficult.
Anything else? Any problem?
Even, sir, other than that,
what is the Achilles heel of pancreaticoduodenectomy?
So the tunnel of love behind the neck of pancreas, making of above the SMV and portal vein.
It is basically the pancreatic anastomosis, isn't it? That is responsible for most. So in this case, what do you expect?
Yes, the pancreas is atrophic and non-dilated duct is there, sir. So PJ anastomosis will be also difficult.
So is it good, bad?
So atrophic pancreas is good, but the non-dilated PD is.
Atrophic pancreas is good.
Sir, the chances of post-operative pancreatic the POPF will be less in atrophic.
Not POPF will remain the same because it is an undilated duct. The consequences of a leak. See, atrophic pancreas, if it is an indicator that there is underlying chronic pancreatitis, then first is that the gland is likely to be firm. The sutures will hold well. Second is it may have exocrine insufficiency. So even if leak occurs, it is not the leak which is important. It is the consequences of leak, the enzymatic autodigestion of tissues, vessel stumps, and other anastomosis, which is the problem. That is why the treatment of any pancreatic leak is drainage. Once you drain the collection, there's no harm done. It is the collection, it is the infection of the collection, it is the erosion of that collection or abscess into the remaining anastomosis or other anastomosis or vascular stumps, which is responsible for the consequences. So while the undilated duct is going to be a technical problem, the anastomosis is going to be difficult. But if the atrophy is an indicator of chronic pancreatitis, that is a good advantage. So that's why it is said that if you are doing a pancreaticoduodenectomy in a patient with chronic pancreatitis, resection is difficult because the peripancreatic planes are not clear. There is a lot of fibrosis. But reconstruction is easy because sutures hold well. Even if leak occurs, not much damage is done to the tissues. So same way, as you rightly said, a patient who has been stented, patient who has had recurrent episodes of cholangitis, there will be a lot of pericholedocal inflammation, which will make the dissection difficult. And if the cholangitis has been recent, then the CBD wall may be vascular, may be edematous, may be friable. So chances of HA leak. That is why if you have cholangitis, you let the inflammation settle, whether it is choledochal cyst, whether it is CBD stone, whether it is PD. You wait for at least 2 weeks. Some people would do it even longer for the inflammatory edema and hypervascularity to settle so that sutures hold well.
Yes.
Any question you have or any other student has online?
No questions online, sir. Chat box.
Chat mein kuch hai? Anybody wants to ask, please unmute yourself and you can ask. So if there are no questions, students, please send me a mail, vkkapoor.india@gmail.com. Write pancreas in the subject of the mail. So I'll share with you the chapters on surgical obstructive jaundice due to pancreas and the operative surgery of pancreas. Okay. Thank you.
Thank you, sir.